All right, so our first talk today is going to be on lung cancer screening, and all of this started with Dr. Claudia Henschke with the Early Lung Cancer Action Program that was run out of Cornell and NYU. So it started out as a small study where they took 1,000 patients who were all smokers, and they just screened them with low-dose CT scans of the chest. And of the cancers that they found that 85% of the cancers were very early cancers, stage 1A cancers. So that was promising. And then this expanded into a larger study of over 30,000 subjects. And again, they just studied smokers with low-dose CT. And again, they found that the cancers that were detected were very early cancers. They also found 80% 10-year survival for lung cancer. And especially 88% 10-year survival for the early lung cancers. This was not a randomized controlled trial. There was no control group, but the results were promising. And so before we talk about the major study that we're talking about, first question is, what is the concept of a low-dose chest CT? What makes it low dose? How do you make it low dose? Is
reduce the MAs?
How much? So when you compare low-dose chest CT to a routine standard chest CT, what is the difference in dose? It's what percentage? Is it 50%, 10%, 5%? About 20%. And that's done by changing the MA. So you don't change the KV. The two major parameters that you would change on your standard CT scanners is usually KV and MA. And standard KV is 120, so that doesn't change. But for a regular chest CT, it's about 200 MA. For a low-dose chest CT, they lower it to about 1/5 of that, to 40 MA. So that's how it's done. So low-dose chest CT is done by lowering the MA for the CT scan, and you can see what it does to the dose. So it reduces the dose to about 20% of the dose. Now, when you compare the images of a full-dose CT here on the left to a low-dose CT here on the right, you'll see that when you look at the soft tissues, that it is a noisier image, right? You see much more granularity here of the image. That's because you're using a lower dose, so it is a noisier image. But because there's a lot of inherent contrast within the lung parenchyma, you can see the blood vessels against the lung parenchyma very nicely here, even on the low-dose CT. So it's good enough to pick out small nodules, which is what we're looking for. So because of the large amount of inherent contrast within the lung, a low-dose CT is good enough to find lung nodules. Now, this is not going to work for the liver if you're looking for subtle lesions in the liver, but this works out very nicely for the lung because you have a lot of inherent tissue contrast because the lung is full of air and nodules are going to be solid, so they will stand out against the air within the lung. So the major study that was done that showed that showed the effectiveness of screening with low-dose CT for lung cancer was the National Lung Cancer Screening Trial. This was published way back in 2011. So this was the first screening study of lung cancer to show reduction in lung cancer mortality. The major result was a 20% relative reduction in mortality from lung cancer in the CT group. So they had patients that were screened with CT, patients who were not screened, compared the mortality of both, and CT screening had a 20% relative reduction in mortality. There was a small overall reduction in mortality. Also, in the screen group, 320 needed to screen to prevent one lung cancer death. So those were the major results from the National Lung Cancer Screening Trial. So then this led to recommendations of who should be screened for lung cancer and for guidelines for insurance companies to pay for lung cancer screening. And so these are the guidelines put out by the U.S. Preventative Services Task Force. They were updated in March of 2021. And this is what we also document in our CT reports to show that the patient fits the guidelines. So patients should have greater than or equal 20 pack-year history of smoking, the age between 50 to 80, smoked within the past 15 years. So if they quit smoking 10 years ago, they're eligible. If they quit smoking 20 years ago, they're not eligible. All right, so that's part of the eligibility requirements. And also, smoking cessation intervention has to be offered for current smokers. So when the referring physician meets with the patient and orders a lung cancer screening study, they also have to document that they have offered advice or smoking cessation intervention. Patient criteria for Medicaid, so this is what insurance companies might use, and Medicaid uses to reimburse us for reading these cases. Very similar, greater than or equal to 20 pack year history. The age range a little bit lower to 77, 50 to 77. They must have smoked within the past 15 years. Absence of signs or symptoms of lung cancer. So patients must be asymptomatic. We document that in our template. If you look at our template for lung cancer screening, it says in there that the patient is asymptomatic for lung cancer. And when the order is written by the referring physician, there must be shared decision-making, which means that the referring physician has to counsel the patient on the benefits and harms of screening, diagnostic testing, and offer smoking cessation. The facility criteria, what the facility has to meet in order to get reimbursed. For this, the CT readers must be ABR board certified or board eligible. Your radiation doses for the standard patient must be less than or equal to 3 milligray. Use a standard reporting system. That's why we use Lung-RADS. And used to be a requirement to submit all our data to a national registry. That is no longer a requirement. So this is, as far as the exposure, this is what we look at, the CTDI vol. You want to keep that less than or equal to 3. The DLP over here, you want to keep that less than 105. So for any facility, these are the benchmarks. Any facility doing lung cancer screening, these are the benchmarks for how you want to maintain the low radiation dose. So we have a structured reporting template, and you'll see a lot of this stuff is in there in our template. We document the clinical indication, the age and the pack years, the CT scanner that's used. We indicate CT scanner. All of this was left over from the required information for the registry when submitting to the registry, but we've just kept it. We haven't changed the template. The technical parameters. So we're documenting all of this stuff for the radiation dose, so it's easy to figure out what dose the patient has received. And then for every nodule you report, every nodule gets a unique number. So if there are 3 nodules on your initial study, you will number the nodules, nodule number 1, number 2, number 3, and that number stays with that particular nodule throughout the course of their screening. So if they had 1 nodule in the right upper lobe, nodule number 1, they had 1 nodule in the right middle lobe, nodule number 2, and then they come back for a follow-up screening and you find a new nodule in the right upper lobe, that becomes nodule number 3. So every nodule has a unique number. That number stays with that nodule throughout the course of their screening. You also document, of course, the size to the nearest what? When we measure a nodule, we're supposed to technically give the measurement to what? Centimeter? Millimeter? Tenth of a millimeter. I don't always do that, but the guidelines are you're supposed to indicate the nodule to the nearest tenth of a millimeter in terms of the size of the nodule. Consistency, we say whether it's solid or ground glass, of course the location, and then there's the Lung-RADS scoring system. At the end, we provide a score for that particular patient, and the advantage of the score is it determines the management. So if we find a 5 millimeter nodule on a smoker, what's the positive predictive value? That is a lung cancer. How confident are you that that is a lung cancer?
Very,
Very, very low. That's right. Extremely low, even in smokers. So in the National Lung Cancer Screening Trial, their criteria for a positive study was a 4 millimeter nodule, actually. And 24% of all their screening exams were positive. 24% of their patients had nodules. The vast majority of those were all benign. Over 95%, 96% of the nodules were benign, especially when they're small. So what can be done to decrease the false positive rate? Well, this is why, comparing to the lung cancer screening trial, we increased the size of an actionable nodule to what? 6, right. So 6 is the cutoff value, 6 millimeters. So you'll see that for nodules of 4 to 6 millimeters, the positive predictive value is extremely low. And once you get more than 6 millimeters, then it goes up a little bit more. So that's why for Lung-RADS, the threshold for a positive result for a solid nodule, what is going to change the management, 6 millimeters. If the nodule is 6 millimeters or greater on a baseline study, that is going to change the management for that particular patient for a solid nodule. So a score of 1 means that you have no nodules that you're concerned about, and a score of 2 also means that essentially there are nodules there, but you're not really concerned about them. So a score of 1 or a 2, that indicates pretty much a negative study. You're not going to change management. What's going to happen is the patient's going to come back for a low-dose CT in 12 months. So if you have a solid nodule or part solid nodule less than 6 millimeters, that does not change management on your baseline study. If you have a ground glass nodule, there you go up to 30 millimeters. Less than 30 millimeters, as long as it's pure ground glass, will not change the management. As the nodules get larger, that's when management changes. So between 6 and 8 millimeters for a solid nodule, that becomes a score of a 3, low-dose CT in 6 months. Nodule gets larger between 8 and 15, then you're worried about 4A. That's a little bit more concerning for cancer. There the follow-up is going to be in 3 months. And then if the nodule is even larger, 4B or 4X, where you're really concerned about cancer, then you have some more recommendations here. Now, when you come across nodules like this, in this category, I see a lot of you just cut and paste this recommendation into the report. You put CT with contrast, PET CT, or tissue sampling, right? And then the problem is the patient comes, the referring physician sees that and orders a follow-up CT with contrast. So honestly, if you have a 1.8 millimeter nodule, is a follow-up CT with a 1.8 centimeter nodule, is a follow-up CT with contrast really going to change anything? No. So what you do is you look at this and you decide what in your opinion for this particular patient is the best follow-up. Many times it comes down to either doing a PET CT, a follow-up in 3 months, or biopsy. And so you can offer the choice, you can offer the clinician the choice. You can do a PET CT now, or you can do a follow-up in 3 months, or if you're really worried about it, you would recommend biopsy. Biopsy this lesion now, we're really worried that this is cancer. Instead of cutting and pasting all of this recommendation into your report, you should sit there and think about what do you think is the best recommendation for this patient, and that's what you should put in your report, okay? So the probability of cancer, you see how that changes as the score rises, and so I've given this to you in your handout also. And one other thing that comes up with lung cancer screening is there is this S category, which is significant non-lung cancer finding. So remember, we're looking at other organs besides the lung. So let's say you see a renal mass that you're concerned about, but there are no lung nodules. So what becomes the score for that patient? The score would be 1S. The S meaning there is a significant non-lung cancer finding, but that's going to require some kind of workup, right? So if there is another finding on the breast mass, renal mass, whatever, that is not related to lung cancer, but requires some kind of workup, you would add the S category to that so the clinician is aware, look, we found something else, we need to look into it, okay? And then this is available to you at all your workstations for, you can refer to this when you're deciding what score to use. Some things to be aware of. The score of a 0, Lung-RADS 0. This means that you see something, but you're not convinced it's a cancer and that it might be inflammatory. And so if we bring the patient back for a follow-up CT in 1 to 3 months, maybe that's going to go away. Maybe it's going to get smaller, in which case it's not something we're going to need to worry about. If that is the case, then you score it as a 0, and then you make the recommendation, bring the patient back between 1 and 3 months. You can specify when, 1 month, 2 months, 3 months, and let's see what happens to this lesion. The mean nodule diameter should be measured to 1/10 of a millimeter, right? So not 4 millimeters, 4.2. So that's why, remember, 6 millimeters is the threshold for changing management. So I wind up squeezing the calipers a little bit and getting it down to 5.8, okay? But you can do that, right? You're allowed to do that. Remember, 5.6 rounds off to 6 millimeters, and that's going to change the management. But if you just leave it at 5.6, it's not. Periphyseal. If you have typical periphyseal nodules, we've talked about these that are probably intrathoracic nodes or intrapulmonary nodes. There the number goes up to 10 millimeters. As long as you have a periphyseal nodule that's less than 10 millimeters, that gets a score of a Lung-RADS 2. That does not change management. All right, so if you have a typical periphyseal nodule that's 9.9 millimeters, it's not going to change management. It still gets a Lung-RADS 2. For ground glass nodules, as long as it's less, it's pure ground glass, no solid components. As long as it's less than 30 millimeters, that still gets a score of a Lung-RADS 2. That will not change management. Okay? So here's an example of a score of 0. There's this funny looking thing here, and I guess that's in the right upper lobe. All right? Doesn't look like a nodule. It's kind of big. Looks like it might be atelectasis or something inflammatory. Okay? So I think let's bring the patient back and see what happens. We bring the patient back 3 months later, it goes away. So that's a Lung-RADS 0. Now their score here, if they have no other nodules, that's going to be a Lung-RADS 1. When is their next follow-up CT? When?
A year.
From when? This study or this study?
You do it from the second.
From the second study, right. So their follow-up would be from the study you're currently interpreting. We'll talk about that too. All right, that was also confusing before. Juxtapleural nodule, which means any nodule that is against the pleural surface, whether it's against the fissure, whether it's in the periphery of the lung, as long as it has the typical appearance of an intrapulmonary node, ovoid, triangular, it's not spiculated, it's not causing distortion, you're not so worried about it, the number, as long as it's less than 10 millimeters, that gets a score of a 2. Does not change management. Okay? So, what do we mean by juxtapleural? Any nodule that is touching a pleural surface, whether it's the mediastinal pleura, the lateral pleura, the diaphragm, or the fissures. The number up to 10 millimeter or less than 10 millimeters will not change management, score of 2. When do you do the follow-up? The follow-up happens from the study you are interpreting. That's when the follow-up will be, not from the last study or the initial screening study, from the study you are interpreting. All right, so that's called step management. What does that mean? So here we have a 10 millimeter nodule, somewhat spiculated. We're worried about this. So we give this a score of a 4A. We bring the patient back in 3 months. It is unchanged. Usually a nodule, if it is unchanged on your follow-up CT, your 3-month follow-up CT, you bump it down one category. So this gets bumped down from a 4A to a Lung-RADS 3. Lung-RADS 3 means the follow-up is going to be 6 months. But 6 months from when? 6 months from this scan. So the next follow-up is here, and on this study, which is 9 months from this one, but 6 months from this one, it is still unchanged, which means it gets bumped down another category, so now it becomes Lung-RADS 2. The follow-up for Lung-RADS 2 is 1 year. So their next scan would be 1 year from this scan. Not this one, this one. Okay? So that's how we figure out when the follow-up should be. All right? Airway nodules. If the nodule is in a segmental or proximal airway, 4A. If it is in a subsegmental airway, way down there, Lung-RADS 2. Okay? So for 4A, they're going to get a 3-month follow-up. If it's persistent at 3-month follow-up, now it's a 4B. Which means you were probably going to recommend what? At that point. No, these are rather small. These are less than a centimeter, right? These airway nodules are going to be less than a centimeter. So if you're worried about an airway nodule, your only option is most likely bronchoscopy. Okay? So if you're worried about an airway nodule, you're probably going to recommend bronchoscopy. Mucus does not count. If it's mucus, we're not going to worry about it. Okay? If you can tell it's mucus. So segmental or proximal airway, 4A. So our baseline study, there's a nodule, looks like a solid nodule, we give it a 4A. 3 months later, the patient comes back, it's still there, now it's a 4B. Now you're going to recommend bronchoscopy. Your only choices are either another follow-up or bronchoscopy at this point, okay? Now, what do we think this is? There's an airway nodule. What is that? So, how do you know?
It's like air in it.
Yeah, it's got these that's mucus, right? It's got these bubbly lucencies in it. That's mucus. Are we going to worry about that? Are we going to score it? No. That does not count as an airway nodule. So if that's the only thing we have on this patient, right? If that's the only problem, we're not going to score that as an abnormality, so the patient will get a Lung-RADS 1. They don't need a follow-up for a year, okay? So is that clear? Mucus does not count. All right, and then we need to talk about atypical pulmonary cysts, which we'll get to. What counts as growth? Greater than 1.5 millimeters, and if you're doing volumetric measurements, greater than 2 millimeters cubed. But in diameter, the average diameter 1.5 millimeters. By the way, how do you calculate? We give one number for the diameter of a nodule, right? We give one number, not two. But how do you calculate that average diameter? I don't think I talked about this. How do we do that?
Isn't it the average of the 3 dimensions?
The average of the two largest dimensions. Right. So you take the two largest dimensions, you take the average, report that to 0.1 millimeters. That is the diameter of your nodule. Okay. And then growth, if that average diameter grows more than 1.5 millimeters. All right, atypical pulmonary cysts. These are important. Almost 10% of lung cancers are associated with cysts, and about 23% of lung cancers that were missed in this other lung cancer screening trial were associated with cysts, all right? So what makes it an atypical pulmonary cyst? If you have a cystic lesion with thickened walls, or if you have a multilocular cystic lesion, that makes it an atypical pulmonary cyst. That is going to require follow-up, all right? So if the cyst wall is less than 2 millimeters and there are no solid elements, that is considered benign. That is not an atypical pulmonary cyst. That does not get scored. That's not going to change management. The number is greater than or equal to 2 millimeters. If the wall thickness is greater than or equal to 2 millimeters, that is an atypical pulmonary cyst. If it's multilocular, it's an atypical pulmonary cyst. If there's an associated nodule, it's an atypical pulmonary cyst. Growth criteria for the cyst is 1.5 millimeter increase in nodule or wall thickness or cyst diameter. Okay, if the cyst is less than 2 millimeters, that is not an atypical pulmonary cyst. This does not get scored. This does not change your management. We don't worry about this, okay? Probably a small nematocele or bulla, does not matter. If it's greater than or equal to 2 millimeters, now we have an atypical pulmonary cyst. The score is 4A. What is the follow-up for a 4A lesion?
It's 3 months.
3 months. No, you're not going to biopsy this. You have to decide, but for an atypical pulmonary cyst, it's 3-month follow-up. All right? It's a 4A lesion. It's going to get 3-month follow-up, and then you're going to see what happens to it. Okay? If it stays the same, it gets bumped down one category, probably to category 3, in which case you would do a 6-month follow-up. If it starts to grow, then you might get worried about it. Mostly air. If it's mostly air, it's managed as a cyst. But if it is mostly solid, this is not an atypical pulmonary cyst. This is considered a nodule. This you would manage as a nodule. Okay? So this would go in your nodule category. This would go in your atypical pulmonary cyst category. Multilocular cyst, that is an atypical pulmonary cyst. That gets a score of a 4A. There's another example over here. Oops, of a multilocular cyst. This guy. Another multilocular cyst. So all of these on your baseline study, these would be scored 4A, which means the patient would come back in 3 months for a follow-up. All right? So here we have an atypical pulmonary, a multilocular cyst actually, that grows. It grows from 23 to 28 millimeters, means it gets bumped up from 4A to 4B. Here's another example where the cyst wall gets a little bit thickened and the cyst grows. That's also going to get bumped up a category, especially if the wall thickness there is increased. Cyst with associated nodule, you manage the most worrisome feature. Usually it's the nodule. So you're going to look at the nodule, and management is going to be based on what you're worried about most. If there's a nodule, it's probably going to be the nodule, right? So this nodule is growing, so we're going to score this based on the growth of the nodule. 4X, that's if you have a category 3 or 4 nodule with additional features that increase the suspicion for lung cancer. Spiculation, lymphadenopathy, metastases, any ground glass nodule that doubles in a year. So if you're really worried about cancer, spiculated borders, lymphadenopathy, evidence of metastatic disease, that's a 4X, which means you probably need to biopsy that nodule. Okay? And then the whole scoring system, it's available to you on the workstations. You know, you can go look through this when you're trying to score any particular case, right? So that is the scoring system for Lung-RADS. Let us now just move on to the next topic here. Oops, not that. Somebody not muted out there? What is that? Whoa.
Still there.
Okay, so our next category, non-neoplastic lung masses. All right. So what is abnormal about this chest radiograph? Is somebody out there, is that somebody out there is not
Yeah, someone
muted?
out there, yeah,
Can we
muted.
send a message? All right. What's abnormal on this chest radiograph?
Seems to be like,
Guys, somebody out there is not muted, so can you please mute? All right. So what's wrong? All right, so what line is this? What line is this?
The descending aorta.
That's a descending aorta. What line is this?
That's good.
No, what line is that?
very spinal.
Yeah, it's the left paraspinal line. What line is this? That's the azigoesophageal line. Which line is abnormal? The azigoesophageal line, right? So there's this big round opacity. The location of this is what? Subcarinal. What compartment would this be? Middle mediastinum, right? So if you have a round subcarinal mass in the middle mediastinum, what do you think that's going to be? So bronchogenic cyst, right? So that's the most common location for a bronchogenic cyst. So here it is on the lateral view, down there. Here's the azigoesophageal line that is deviated. Let's look at it on CT, and my question for you is it the bronchogenic cyst?
There's enhancement.
Doesn't really look like a bronchogenic system.
Why not?
Well, you expect them to take up more space rather than.
What's different between the left and the
There's
right?
incidence as well.
Yeah.
Okay, so the difference is this is pre-contrast, this is post-contrast. Is the lesion enhancing?
Yes.
Partially.
Yes, it is enhancing, right? So, there, taking the ROIs for you. So this lesion is enhancing. So it can't be a bronchogenic cyst. Bronchogenic cysts can be high in attenuation on non-contrast CT. They can have proteinaceous fluid. They might even have hemorrhage. But they should not enhance. If you have an enhancing lesion, now we have a solid mass, not a bronchogenic cyst. What could this be?
Lymphoma.
All right, so it could be lymphadenopathy from lymphoma. What else can cause lymphadenopathy?
Infection.
What infection?
TB.
Yeah, this was actually a case of TB causing infection, subcarinal nodes. Metastatic disease from any source can give you lymphadenopathy, right? Could it be a benign lesion, not a benign lesion, but could it be some kind of neoplasm related to the esophagus? What would that be?
Like a bad squeeze.
Well, squamous cell usually causes circumferential esophageal thickening, right, and obstruction of the esophagus. That's not what this looks like. What's the tumor that grows outside the esophagus, in the wall of the esophagus? Yeah, and the term we use now is GIST tumor, gastrointestinal stromal tumor, right? So that might also be in your differential diagnosis for a soft lesion like that. So you want to see, does it involve the esophageal wall or not? Here we have another lesion, nice subcarinal location. There it is, on the lateral view. And then this one, there, here, pre-contrast, post-contrast. This does not enhance. This is a bronchogenic cyst, okay? So this lesion is in the lung parenchyma, or is out there in the lung, right? Between pre-contrast and post-contrast, there's no enhancement. What is your differential? What could this be? So you have a fluid attenuation lesion out there in the lung. What could it be? What do you mean a loculated cyst?
Like a simple cyst.
A simple cyst. You get simple cysts in the lung? What gives you simple cysts in the lung? Well, first, if it were in the fissure, what would you call it? No, not in paema, but what's the term for loculated fluid in the fissure? Pseudotumor, right? So that if it were in the fissure, you'd call it a pseudotumor, right? That's not quite in the fissure. The fissure is more interior at that location. If it's in an airway, what would you call it? Yeah, a mucocele, right? So it could be a dilated airway filled with mucus, so it could be a mucocele. Well, those are some possibilities, right? You said a cystic lesion in the lung parenchyma. What can give you a fluid attenuation, well-circumscribed cyst in the lung parenchyma? What could that be? Hydatid cyst is pretty rare. I'd mentioned something before that, though. What would I mention? Can bronchogenic cysts occur in the lung parenchyma? Yeah, up to 30%. This was another bronchogenic cyst. So the subcarinal location is the most common location for a bronchogenic cyst, but they might also occur in the lung parenchyma. This was a bronchogenic cyst. I like hydatid cyst, though. That also is in your differential, and not something that people think about for a well-circumscribed cyst fluid attenuation lesion in the lung. Before it ruptures, it might look like that. Okay? Bronchogenic cyst. This represents cystic reduplication of the tracheobronchial tree. Most are in mediastinal, 30% in the lung parenchyma. If it ruptures into an airway, you can get an air fluid level in these things. So that might also occur. That is possible with a bronchogenic cyst. Okay. Sometimes you might have some calcification within the cyst wall. That can also occur with these bronchogenic cysts. And bronchogenic cysts can be high in attenuation on non-contrast CT, but there should not be any enhancement with bronchogenic cysts. Right? So pre and post contrast, really not much enhancement there. Even on MR, they can be higher than fluid on T1 because of proteinaceous contents, but on T2 weighted imaging, it will be very bright, like you see here. So because of the fluid characteristics, it will be very bright on T2 weighted images. Move that thing. And so post-GAD, no enhancement. Even with MR, we don't get enhancement with bronchogenic cysts. All right, so this patient has a kind of a vague retrocardiac opacity. Here it is on the CT. We have this thing over here in the left lower lobe, right? And what do we think of the surrounding lung? Lucid, right. So it's lucid from what? Air trapping, right. There's air trapping in the surrounding lung tissue there. Okay. So, any idea, any clue here on what this might be?
There's like arterial supply.
So the question is, right, so what's going on here? Where are these vessels coming from that are going to the lesion? And so when we look at this, what do we notice?
It's straight from the urine.
Yeah, so there is a vascular supply here, and it's coming from the aorta. So you have a systemic arterial supply, which means the lesion is what? Pulmonary sequestration, right? So that's a pulmonary sequestration. So the next question I'm going to ask you is it intralobar or extralobar? And how do you differentiate the two?
This looks like it's intralobar.
How do you know?
It's above the diaphragm.
It's what?
It's above the diaphragm.
They're both above the diaphragm. They're in the, they're lung, they're both lung tissue. Both sequestration is in the lung, right? So it has to be above the diaphragm. The lesion itself has to be above the diaphragm, right? So this is the arterial supply, right? The arterial supply to sequestrations can be from above the diaphragm or below the diaphragm. But what about the venous drainage, if you're trying to differentiate intralobar from extralobar?
So whether it goes like into the pulmonary veins or
So where's this draining? So here's the arterial supply here. What are these guys? These are pulmonary veins. So it's drained, it's got pulmonary venous drainage, which means it's going to be intralobar, right? You also have a clue that there's air trapping around the lesion. So it's intimately related with the surrounding lung tissue. That's what you see with an intralobar sequestration. What makes it an extralobar? What makes something an extralobar sequestration? What's the difference between intralobar and extralobar? That terminology. Well, that's more likely, but the term itself, why do we call one intralobar? Why do we call one extralobar? Extralobars have a pleural covering. Right? So extralobar sequestrations have a pleural covering. They're more sharply demarcated from the surrounding lung. The extralobars tend to have systemic venous drainage. The intralobars tend to have pulmonary venous drainage. Right? So that's a difference in drainage of sequestrations too. So what is it sequestered from? It's really sequestered from the tracheobronchial tree. It has no normal communication with the tracheobronchial tree, but we recognize it by a systemic arterial supply to this massive lung tissue. That's how we recognize the sequestration. The pleural covering is what differentiates intralobar from extralobar. We talked about the venous drainage. Both are more common on the left side. Congenital anomalies more common with extralobar sequestrations. They're also more common in males. Also more likely diagnosed at an earlier age because of the other anomalies that can be associated with it. Infection is more common with an intralobar sequestration. It is said that the pleural covering protects the extralobar sequestration from infection. So a common presentation of sequestration in a young patient is recurrent pneumonias. So recurrent pneumonias, you find a lesion at the lung base, that's a common presentation for an intralobar sequestration. So this is an extralobar sequestration. So again, we recognize it as a sequestration because it has a systemic arterial supply, very sharply demarcated from the surrounding lung tissue because it has a pleural covering, right? So that's an extralobar sequestration. We look for opacities at the lung base. The key finding, of course, is the systemic arterial supply. It's important to know where that systemic artery is coming from, whether it's the thoracic aorta or the abdominal aorta, especially if they're thinking about surgery to remove the sequestration, because if it's coming from the abdominal aorta, you do not want the surgeon to lose that arterial supply during surgery, or the patient will bleed out into the abdomen as it retracts below the diaphragm. Right? So it's very important to be able to say where the arterial supply is to a sequestration. Another example, mass at the lung base, they can have a complex appearance with fluid within them, and then you see this large artery supplying the lesion, so that is a sequestration. Another one, systemic arterial supply, surrounding air trapping, surrounding episeminous lung. That's a common finding associated with sequestration. Here's a young patient who has a cavitary lesion there at the right lung base, and it bled a lot. The patient required angiography for possible embolization. And on angiography, they see that it has an arterial supply, and it's got all these funny-looking vessels coming off the intercostal arteries, right? What do we call this lesion?
CM?
No. It's got a systemic arterial supply. This is sequestration. Well, the term for this is pseudo-sequestration. So what this represents is an acquired inflammatory lesion. What happens with chronic infection is that you can have parasitization of the surrounding blood vessels. And rather than one well-defined feeding vessel, they can have these small, funny-looking vessels that are supplying it, which are friable and prone to bleed, which is why the patient has hemoptysis. So neovascularization of chronically inflamed tissue can result in pseudosequestration. So the blood supply is from hypertrophied vessels rather than a large anomalous vessel. Right? It could be bronchial arteries or intercostal arteries or other arteries. So that is an acquired lesion, that is pseudosequestration. What do we think of this chest radiograph? What's wrong here? Which lobe?
The right lower.
The right lower lobe? See anything behind the heart?
Yeah.
There's a big mass here, retrocardiac region. What do you think that is?
Looks like possibly cavitary.
Yeah, it looks like it's cavitary. So what do you think that's going to be?
Oh, that could be a hernia.
What kind of hernia? So the most common cause of a retrocardiac lesion with air in it is just going to be a hiatal hernia. Okay, so you have a retrocardiac mass there, and you think there's air in it. That's probably going to be a hiatal hernia. Very easy diagnosis with CT. Okay. So this guy on the lateral view has a mass where? See the mass on the lateral view?
Right diaphragm.
Yeah, big
Posterior.
mass right
Yeah.
there. Okay. So, by the way, which diaphragm is that?
It's the right.
Is that the right diaphragm? Here's the right diaphragm. Which diaphragm is that? That's the left diaphragm. Here it is here. So what is this? So this is the typical appearance of octilic hernia. Right? Gives on the lateral view, usually gives you this nice rounded mass over the posterior costophrenic angle. And it's just got fat in it. You can actually see the defect in the diaphragm on CT. Fat herniates up through there into the chest. That is a octilic hernia. Okay? What is this called? That's a Morgagni hernia. Right. So that occurs at the cardiophrenic angle. That's a Morgagni hernia. All different types of hiatal hernias. You can have sliding hiatal hernias, paraesophageal hernias, where the stomach there comes up. It can be intrathoracic, but the gastroesophageal junction stays where it normally is. So the whole stomach sometimes can be up into the chest with these hiatal hernias. Very easy diagnosis. Air fluid level on a chest radiograph behind the heart, we think hiatal hernia. Easy diagnosis with CT. Octilic hernias, they occur posteriorly. They increase in frequency or in incidence with age because over time the aperture gets larger and larger, especially if there's increased intra-abdominal pressure. And on the chest radiograph, you typically see a round hump over the posterior lung base. And it's got fat in it. So this is the typical appearance, this rounded mass over the posterior aspect of the diaphragm. On CT, it's just fat in there that's herniating up from the abdomen. The foramen of Morgagni hernia, this occurs anteriorly at the cardiophrenic angle. Here's a case where you have this large thing here. It's got like air in it. What is going on? That turns out to be herniated colon within a large Morgagni hernia. Here we have this funny round mass there on the right side. There it is. Here is the CT. What are we looking at? Yeah, it's enhancing the same as the liver, so it's contiguous with the liver. So what is it? What explains this? It's an extra lobe of the liver. It's herniation of the liver. The clue here is that what's the history? Old rib fractures. Right? Patient had trauma. So what does this represent? It's a diaphragmatic hernia from a rupture of the diaphragm that was associated with distal trauma. You see that indentation, by the way, of the liver over here? What sign is that? Where it narrows at the aperture, where it's going through the hernia, that is called collar sign. Collar sign, yeah. So that's hernia from an old rupture of the diaphragm, okay? This, of course, we all recognize as rounded atelectasis, right? Common tail sign, pleural abnormalities. The underlying disease in this patient would be, what's the underlying disease? Not asbestosis. No, absolutely not. What do we call this? It's asbestos-related pleural disease, right? What is asbestosis? Asbestosis is nobody knows what asbestosis is? That's parenchymal fibrosis from exposure to asbestos. Pleural disease from exposure to asbestos is asbestos-related pleural disease or asbestos exposure. Right? That's pleural disease, not asbestosis. So that's rounded atelectasis. Kind of recognize that. Right? Pleural-based mass, abnormal pleural common tail sign, volume loss, all of that goes with rounded atelectasis. This guy has this big round thing over there. Everybody thinks it's a lung mass. He goes to CT. What does it turn out to be? What? The patient has cough and fever.
Pneumonia.
So this turns out to be pneumonia. What do you call it when a pneumonia is round? Round pneumonia. That's right. That turns out usually it's more common in kids. Once in a while you'll come across it in adults where pneumonia is round. It looks like a mass. They treat the patient. Everything goes away 3 weeks later. So that's round pneumonia. Can be anything but strep. Strep pneumonia is the one that we mentioned for round pneumonia. Right? Funny looking opacity there. Funny looking mass over there. Measures fluid attenuation. We call this a loculated fluid collection in the fissure is called a pseudotumor. That is a pseudotumor, yes. So that's just loculated fluid in the fissure. It conforms to the boundaries of the fissure. CT confirms the fluid attenuation, the classic appearance in the minor fissure, biconvex, extends across the fissure, follows the anatomy of the fissure. That's just what it looks like when it's in the minor fissure. When the effusion goes away, the tumor goes away. That is a pseudotumor. Okay. Fluid attenuation, very easy diagnosis in the fissure. This guy has this funny looking lesion over here, right? What is this going to be? Congenital bronchial atresia. So you recognize it by branching mucoid impaction, that's mucoid impaction, the branching tubular opacity, and the surrounding air trapping. So branching opacity from mucoid impaction with surrounding air trapping, that is congenital bronchial atresia. Here it is here, air trapping surrounding the lesion, that's mucoid impaction. So distal to the atretic bronchus, you get mucoid impaction, and then distal to that, you get the air trapping. So that's congenital bronchial atresia. All right? So here's a MIP reconstruction showing you the bronchial atresia. This is a MINIP showing you the air trapping, and then here's just this, like a reconstruction, coronal reconstruction showing you both. So left upper lobe, apical posterior segment is most common, then left lower lobe, then right middle lobe. Look for the branching tubular opacity from mucoid impaction, distal to the atretic segment, air trapping in the surrounding lung. Okay, so that's what we look for congenital bronchial atresia. So branching opacity, surrounding air trapping, mucoid impaction, surrounding air trapping, that is congenital bronchial atresia. That's what we look for. Okay, big mass. On the lateral view, it's located in the anterior mediastinum, yes. What is it doing on the CT? Yeah, it's invading the chest wall. Now, of course, malignancy is in your differential diagnosis, but what benign diseases could do this? What are infections that can involve the lung, mediastinum, and extend through the chest wall? Notice other
Cardiac actinomyces.
Yeah, so start with TB. Tuberculosis, right? Tuberculosis and actinomyces, right? Those are two in immunocompetent patients. In immunosuppressed patients, nocardia. This was actually nocardia in a patient who was HIV positive. But TB, actinomycosis, nocardia, those are infections that can involve the lung and extend into the chest wall. Okay? And then this patient had this thing here that everybody thought that was going to be a lung cancer. It goes to PET CT. There it is. It's lighting up like anything. That's got to be a lung cancer. It was actually biopsied 3 times because nobody believed the biopsy results. And this turned out to be organizing pneumonia. Not that whenever you see this, you're going to say organizing pneumonia. You're going to say lung cancer, I hope, every time you see something like this. But the point is, sometimes there are these inflammatory lesions that will look just like lung cancer. Okay? Sometimes they'll get you. All right? So that is our discussion of non-neoplastic masses.